session. This one is entitled Hernia Center Specialization and Practice Advancement, Why and How. We have as many moderators as we do speakers, I think, so we'll try to keep it interesting and engaging. Flanked by Dr. Dana Tellem, Dr. Sal Dossimo, Dr. Lucian Pennant. And I'd like to have the privilege of introducing our first speaker of the afternoon, Dr. Todd Henneford. He'll be speaking to us about mentorship, and quite timely, as he had received a notable award this morning, and he is truly a mentor's mentor. So thank you, Dr. Henneford.
Professor Ross, thank you. And so I really gave my, this lecture this morning, and thanks to the American Hernia Society for allowing me to actually talk about mentorship and education and receive that award. And these are my disclosures. And as I said this morning, the greatest disclosure that I have is that if there's anything that you see in any of my lectures that are worthwhile, it comes from these people. It comes from the young people that we work with. And indeed, it's been the greatest honor of my career to actually serve as a teacher. And if I'm hopeful, to serve as a mentor. And I see those two, see that relationship. I see the relationship is different. There is, I think there's real meaning in mentorship versus being a teacher. And indeed, so the consideration of like these young people, and why would young people actually want to do hernia surgery? I mentioned this morning, like when Will Cobb was a fellow, you didn't say that you're going to do hernia surgery. You never came to do hernia surgery. You came to do minimally invasive surgery. And at that time in my career, we were actually doing a ton of minimally invasive surgery. We did do some hernia repair, and we actually had written a bit about hernia repair, but we were most known for doing minimally invasive surgery. And indeed, why would I migrate from doing pancreatectomies? We had some of the largest years in the world of pancreatectomy and gastrectomy and pheochromocytoma and adrenalectomy produced in the world minimally invasively, but because that wasn't where my passion was. My passion actually was in hernia repair. And why would that be so? And why would it be so for young people now? And I think that, indeed, one of the reasons that young people now, and the last time we went through the fellowship council, we had 128 people apply for one fellowship position. It really is quite incredible. And so why would young people now actually see this as something that they would pursue after 5 years of general surgery, 4 years of medical school to do as a career? And I think one of the things is we've been able to demonstrate complexity. And I think that there is indeed surgical excellence involved in performing these operations, and they can see a real difference in people who truly apply themselves in hernia repair. There is a lot of ways to fail. And of course, there's mentors, and I think that they see there's a team effect. Indeed, there's technology in the scientific growth. There's certainly research opportunities, and they can see that their work makes a difference. And they can actually, those mentors that they see that they can actually possibly reach to become them and develop and become a master. And as well, through the work through the European Board of Surgery and Ferdinand Cochlein, you can actually, even in the United States, you can become board certified through the European Board of Surgery in abdominal wall surgery and in hernia surgery. But I think the most important reason why young surgeons are actually coming into and accepting to become an abdominal wall reconstruction surgeon or abdominal wall surgeon is because of approachable heroes. And indeed, if you look at what qualifies as a fellowship, if you're going to become a mentor and you're going to develop a fellowship, the Fellowship Council has tried to come up with requirements for a hernia fellowship, and this was their first go at this. And they and indeed they're doing their best. They're trying to see how do you qualify for a hernia fellowship. And if you look at these numbers, 174 procedures, I think that's fine. 30 inguinal hernias. 15 laparoscopic, 10 must be recurrent. I guess that's certainly helpful. And then, of course, 50 ventral incisional hernias, 25 recurrent hernias, and 25 have to be robotic. 50 component separations and 25 have to be robotic. I see that as actually almost unattainable in most programs. And Ben, I don't know if you would agree with that or not, but I wouldn't qualify as a hernia fellow myself. And then they changed this, and so they're working their way through what a hernia fellowship might be. But I think one of the things that you can see is where the residents and fellows are coming from. And if you look at some of the most recent papers written about the competency in abdominal wall reconstruction and hernia repair. They have graduating residents have low confidence in open abdominal reconstruction, MIS hernia, tissue repair, inguinal, but high confidence in MIS ventral hernia. I guess that would also include robotic and umbilical hernia repair. And if you look at there was a study done looking at 20 years of case logs, of resident case logs, and there was a significant increase in MIS, and I would assume that's probably even robotic inguinal hernia repair, and a significant decrease in open inguinal hernia repair. And I will say, we have fantastic surgical residents at the University of Chicago, but so interesting, I had a chance to talk to one of them just recently doing an open inguinal hernia repair in their local anesthesia. They had never seen it, and they had done less than 5 open inguinal hernia repairs in their career as a surgical resident. So it gives us a great deal of opportunity. And so as an attending surgeon who does hernia repair and really enjoys mentoring students and mentoring residents, I'm not the only one that's doing this. And we're seeing this actually across the United States and across Europe. And there's some these are all in Europe, great opportunities in Europe for those across the pond. But indeed, how do you mentor residents, and how do you mentor fellows? And I love this slide. And this student, I stole this from Newt, and it showed this transition in pictures, like in this drawing, and getting better and better and better. And I talked, the art of surgery is perfected through deliberate, humble, resilient, and well-proctored practice. And I think that's what you have to do, and you should do for your fellows. And I mentioned this morning, like the greatest job I have ever had is being a fellowship director, being a fellowship mentor. And Sully Uzo gave me this slide. Surgeons are meant to love their mentors. Every surgeon in every part of the world has indelible memories of their mentor, the person who trained them in surgery, the most dramatic discipline. And I think that, and I just had ChatGPT draw this picture for me about a young surgeon standing there and looking at his future, and about hernia repair. And of course, I wrote like Endeavor abdominal wall health up there. But this is a wonderful opportunity as surgeons are bleeding into this, coming in to do abdominal reconstruction, to develop a fellowship. And I put this slide in, and I had a discussion with Brittany in the back when she looked over my shoulder about that slide, and she said, well, Dr. Henneford, do you know what's that article about? And I told her I had no idea. So I just put that in there, and just because I have no idea. But I think that the consideration of if you are going to develop a fellowship, if you're going to be a mentor to young surgeons, I think that one of the things, as we talked about this morning, one of the things that's super important is that you have to have the tools, and you have to have the accessibility. You have to give of yourself to your fellow. And so indeed, the essential tools, it depends on this as just a graph of like robotics. And so if you're going to be a mentor in robotic surgery, then be a mentor in robotic surgery. If you're going to be a mentor in robotic hernia surgery, be a mentor in robotic hernia surgery. But give them the tools, and you have to invest in yourself in that. You have to be deliberate, and you have to be present. And I would encourage you, those of you young surgeons who want to have a fellowship and want to do this, it's the greatest job in the world. And thank you very much.
Thank you so much, Dr. Henneford. We'd like to ask Dr. Will Cobb to come up and talk about working with industry partners to advance hernia.
Thank you, guys. Certainly an honor and really cool to get to follow my mentor after that wonderful talk. And so my job and my task was to speak about working with industry partners to advance hernia care. My name's Will Cobb. I'm in Greenville, South Carolina, with Prisma Health and Alfie Carbonell, Jeremy Warren. So we used to be down the road from Dr. Henneford, but he moved away from us. I guess we ran him off, but it's still a great place to be, and have a really good partners down there. So, it's interesting. This is a talk about industry, and I can honestly say, if you go by the letter of the law, the last 24 months, I have nothing to disclose with industry. I've not had any involvement, but that's really not the whole story. My life and my career has been significantly impacted in a positive manner by my relationships with industry over the years. Todd showed some pictures. This is a one I dug up when we were in Charlotte together, and you can see Alfie Carbonell there with a full head of hair. So this just shows the age on this picture. But to have the ability to be able to work with, Dr. Henneford and Kent Kirscher and Brent Matthews, and have Alfie in the lab with me, and then Mike and Yuri came the next year and ruined it all. But just amazing that I had that access to just bright minds and just incredibly motivated people, which really set me off on a great course forward. Throughout the years, working with industry and teaching other surgeons and teaching technique and putting on courses, got to actually sometimes hobnob with really famous people, and Mike Ditka as well, the coach of the Bears there, on a picture with the big guy and me. Also, our fellowship, once we got to Greenville, was funded by industry. And that's how we got started in training additional minimally invasive and hernia surgeons, as Todd was mentioning. And our first fellow was Conrad Balliser. So again, he had a whole lot more hair as well. But then I like to bring this picture up. There was a meeting they had once a year for all the fellows that Henneford and Bruce Ramshaw, Adrian Park were instrumental in putting together, where they, with industry support, would bring all of the fellows from that year's class together. And so we got to meet each other, still develop great friendships, which last to this day. And this was Conrad killing it on Guitar Hero. And so, when you work with industry, certainly, like I mentioned, incredibly beneficial. But you do kind of walk a fine line, right? Because there's a sense that, you're dirty, or you're not, you're just doing things for money and things like that. You're following, you're basically a shill for industry. But, the reality of it is that industry has a lot of financial resources that you don't otherwise have. And so when you start thinking about embarking on research projects, putting together multidisciplinary trials, reaching out to other surgeons, going to courses, training, either yourself going out to learn, or if you're participating in the educational aspect of that, that's not without cost. And so I think industry is certainly a resource to allow you to be able to do that. Industry shares a common goal with us, right? At the end of the day, yes, they're selling products, but they absolutely are out to improve patient care. And I think that's vitally important as well. And industry should be looked at as a partner in a lot of these things. They're invested in education. It's to their benefit as well to train outstanding surgeons in whatever area it is. As additionally, they have a lot of knowledge of, mesh and their product and things like that. So you can learn a lot from their scientists, because they have really smart people working for them as well. When I think back and when I was putting this talk together about some of the advancements, at least in my career, that I think have been significantly advanced with assistance from industry, it certainly wouldn't have happened as quickly. I think about lightweight mesh. I think about the role and the studies that have been done most recently on bioabsorbable mesh, hernia registries, and then obviously robotic surgery. And so with lightweight mesh technology, one of the first things that I kind of got handed when I came to Charlotte, I was incredibly impressed. The first research meeting, Alfie Carbonell was running the entire meeting and going through the projects coming up, and they were getting ready to embark on this huge study looking at all the different weights of mesh. And, this had been Todd's idea, and he'd been working with Ethicon at the time. And they were having a lot of issues with how to pull off this study, how to actually do a ball burst test and not drag the specimen. And so Alfie was like, we figured that out. We figured that out a long time ago. It's all good. We're going to do this study. It's going to be great. And so we walk out of the meeting and I said, Alfie, that's amazing. You guys have already figured. He's like, dude, we ain't figured out anything. That's your job, man. So that was the great thing about being in that environment and getting to figure that out with the orthopedic engineer. And so with the support, we actually operated on, I believe it was 18 mini pigs, which grew up to be mini hogs over 6 weeks. And that's a lot of money. That's a lot of time and effort. And these things, again, aren't cheap. And so industry was the only way we were able to get this study done. But, over time, certainly learned after explanting these specimens, the importance of lightweight mesh at the time, reducing the amount of polypropylene, which maybe we made it a little too light or went a little too far. But I think what really came out of this was the concept of macroporous mesh and the concept of bridging fibrosis. And so even today, one of the few things I think we agree upon in hernia is that a macroporous synthetic mesh, when used, is the preferable compared to microporous materials. So bioabsorbable materials, again, this was a solution that was offered. We were at the time only had biologic meshes really available to us, and we were having varying results with those. I think industry stepped in, they sort of answered the call, presented some synthetic materials, different type materials depending upon the company that produced them. But the idea was that you had synthetic materials that reliably degraded. And so unlike our biologic materials at the time, which were unpredictable, this really gave us the ability to place a graft that we knew was gone in a set period of time. When you look at these studies, I mean, these are massive multi-center trials. Mike Rosen put this one together to look at one of the products. And, when you think about a 2-year follow-up and what's involved in getting those patients to come back and getting all the surveys and the quality of life data, that's an enormous undertaking. Again, that would not have happened without our industry partners. And so, this study just showed a 17% recurrence rate at 24 months. And then Dr. Roth here to my side, he put together another study looking at a poly-4 hydroxybutyrate mesh with a 5-year follow-up. So that's incredibly impressive, particularly in the hernia literature, as you guys know. Very respectable hernia rate, or recurrence rate rather. And these studies don't happen without the support and funding of industry. Hernia registries, we've always, criticized the follow-up and the data that we have, and we haven't really learned from our European colleagues who've done an outstanding job over the years putting together registries. The Abdominal Core Health Quality Collaborative, it's the best we have. Is it perfect? No, but it is the largest U.S. registry, over 150,000 patients to date, and significant support from industry makes that happen. When you think about the contributions and the papers that have come out of the QC, I think the next one will be 200 there, Ben. So, a lot of significant work and a lot of significant folks, not just in academia, but also private practice that have contributed and used this data to write manuscripts from that. Will Hope put together a paper looking at the databases that are currently out there. And again, as I mentioned, the Europeans have been doing this for a long time and have really led the U.S. in that sense. And when you look at the different databases, really the Danish hernia database is the only one that's mandatory. So the patients are automatically enrolled. The other databases that are out there are voluntary. And then the majority of these are industry funded. That's how they're able to have these large databases. Only the Danish and the Swedish registries are publicly funded. Robotics, of course, I don't need to tell this crowd, but the trends in robotics, you can't be the old guy in the room, telling the kids to get off your lawn because it's here. I mean, it's taken over. The trainees certainly want to learn robotics. They're desperate and hungry to learn this new technology. And, this has advanced dramatically, of course, with the help of industry, with training folks. We would have never trained this many surgeons to be safe and learn these procedures without our assistance with our industry partners. I look at our volumes, general surgery, there's a reason they're going after hernia and gallbladders and appendectomies. That by far is the fastest growing area at our hospital. This is our inguinal hernia volumes, which is, it's good to see the laparoscopic volumes haven't plummeted. We're actually taking open cases and moving them to the robot. So that was the intent, was making them minimally invasive. Obviously, the ventral hernia is a little bit more challenging, certainly a much more difficult technical case, but you're seeing that advancing from a robotic standpoint as well. Can't mention robotics and training without bringing up the International Hernia Collaboration, the Facebook group that Brian Jacob put together. But a lot of folks have put time and effort to put content on here, critique cases real time. They've taken this as well across outside the United States. They have an annual meeting in a country outside of the U.S. And so there's been a real effort for an international outreach. And this has had significant impact in advancing hernia care as well with the support of our industry partners. You have to, like I said at the beginning, you're walking a fine line. And so we do have to be careful. And there are some literature out there that just talks about how we're not maybe as open and honest as we should be in reporting our conflicts of interest. So this is a paper looking specifically at the ventral hernia literature. 70% of the papers had a conflict of interest. The self-reporting was discordant with what was matched up on the Open Payments website in 63% of those. And these authors suggested that the presence of the conflict increased the favorability of this study. Another paper by a separate group, again, same theme here, is that a lot of conflicts that aren't being reported. And so obviously, I think it's incumbent on us to be accurate when we are publishing, and there's nothing to be ashamed of in reporting our conflicts of interest. Interestingly, in this paper, the last authors, who are usually your senior authors, were at highest risk of not disclosing their payments. So I thought that was a interesting caveat there. And so just from sitting at it from the dark side, so I do a lot of administration now. I really just see patients one day a week and operate on Fridays. But we have a meeting once a year where the corporate compliance folks from the organization get together and review every physician that receives more than $5,000 on the open payment site. And it's not a got you. It's not that, we're going to call anyone and ask for money back. It's really just to make sure that they are reflecting that in their conflict of interest statements. This obviously has implications if folks are on the policy, Pharmacy and Therapeutics Committee or on the OR Products Committee. And so if they're in those key decision-making roles, they do have conversations with those people following this meeting. And so again, I'm sure something like this is happening at your institution as well. And so this is being looked at. And so again, I think partnerships with industry can be extremely beneficial for our patients. Certainly provides funding for research and educational activity, and I think has tremendously advanced hernia care more rapidly than it would have without their help. And then I do think it's incumbent, like I mentioned, on us to be more transparent and responsible in our conflict of interest reporting. Appreciate it. Thanks for your time.
All right. Thank you, Dr. Cobb. Appreciate it. Next up is Lucien Panay. He's going to be discussing specialty designation in abdominal wall surgery. And where are we and where do we need to go?
Thank you very much for the honor of the podium. These are my disclosures, and the goal of today's presentation is to update the audience on the American Hernia Society efforts in establishing recognition for excellence in hernia care, specifically in the work performed with focused practice designation for individual surgeons and center of excellence designation for institutions. And I will start with my journey. A few years ago, I moved from Atlantic City to Minneapolis. I love hernias and I wanted to start a private practice, and I reached to a few colleagues for advice, and they are all successful surgeons running their own practice. Thank you, Shirin. She's here in the audience. Interestingly, what they had in common, they all ran a hernia center. So it seemed appropriate to name my practice the Minnesota Hernia Center, but I had to wonder, is this the right thing? What is a hernia center? It's just me and one other employee. So I had some doubts about the name, but I decided to fake it till I make it, and I ran with it. But what is the current state of specialization in our field? Our European colleagues have done a great deal of work and have established a fellowship in the European Board of Surgery with a concentration in abdominal surgery in 2021. And they have two pathways for that. One is a honorary fellowship for people with extensive experience, but otherwise people need to pass two parts of this examination. With regards to hernia centers, they leave it to the individual boards of specific countries to define the criteria for those, so they don't really give any advice. In the United States, things are at this point a little bit more hectic. There is a private institution that certifies both institutions and centers, but they don't have the greatest reputation. There are self-proclaimed hernia centers, and if we look at the map of New York City, we can see a combination of private practices, institution, and university practices. Certainly, the name of my practice falls over there too. So we have to wonder, are these marketing ploys? And marketing is important in growing a hernia practice, but I think in the end, we all have a common goal to demonstrate to the patients and other doctors that we care about and are committed to excellence in the hernia field. So things took a turn about 2 years ago when former president of the American Hernia Society, Dr. Novitsky, established the abdominal wall surgery specialty designation task force. And I had the honor to be a co-chair for this task force. We selected 25 people from a mixed background, private practice, academia, to help with two tracks, one focus practice designation for individual surgeons and the other one Center of Excellence designation. And thank you, Scott and Sal, for the amazing work that has been done by your teams. And our goals were to define criteria and pathways for complex abdominal hernia surgery, specialty designation, and we decided to have this endorsed by the American Board of Surgery. So this will be a surgeon-specific designation, and also for institutions, like I said, Center of Excellence designation, and this will be an American Hernia Society driven. We did not want to infringe upon a general surgeon's routine hernia practice or redirect patients from institutions that are already dealing with hernia patients. And why did we think this is important? Our hernia field has seen increased complexity in the last 10 years. Our Hernia Society has grown tremendously, reaching almost 1,000 members now. And there are 21 abdominal fellowship programs in the country, graduating 25 fellows per year. So there is increasing momentum and increased interest in the hernia field. And we think we deserve to be recognized for the work that is done. There are two pathways that the American Board of Medical Specialties define. One of them is subspecialty criteria, but that requires fellowship training, so we didn't think this is appropriate for us, so we chose to follow the focus practice designation. And there are other precedents in the surgical field. The closest to us is the metabolic and bariatric surgery, which was established a few years ago. It was the first focus practice designation in the general surgery field. There were some hiccups, but we tried to emulate their model, and we decided this is the best pathway for American Hernia Society to follow. We reached out to the membership to gauge interest. Most people who responded to the survey were interested in both FPD and COE designation for their institutions. However, there were concerns, and most concerns were that these designations would take patients away from individual practice and direct patients to tertiary centers. And this is not what we try to achieve. The way this pathway was built was based on the main pillars of a hernia surgeon, which we thought to be dedication, training, volume, and quality. And the qualification requirements are listed here. I will not go through all of them, but the most important things are people need to have at least 3 years in practice. There will be a fellowship pathway, but also a non-fellowship pathway as well as a merit-based pathway for people who have been doing this for a long time. And it needs to be a certain number of cases. Some of them will be simple cases, but importantly, some of them need to be complex cases. We divided them into tiers, and I will show them on the next slide. And also, there will be a test in the future, and a certain number of CMEs people need to achieve and renewal every 5 years. And the case requirements need to be 500 lifetime and 100 per year. And of this, 200 need to be complex or tiers 2 and 3. We did not try to reinvent the wheel. We got inspired by our European colleagues who defined also these complexity levels, and we made some slight modifications to fit our membership better. So where are we at this point? We have already engaged with the General Surgery Board of the American Board of Surgery and received feedback. We engage with other stakeholders, other surgical societies, and receive feedback from some of them. We will incorporate the ones that we consider appropriate and submit a formal application to the American Board of Surgery, which will further push this to the American Board of Medical Specialty. The second pathway that we've been working on is the Center of Excellence designation. And again, this is a designation for specific institutions. Dr. Dosimo's team had put a great deal of work in defining the criteria. I will not go through all of them, but there is a case volume number, and there is institution commitment and a need for a program director to supervise all this. There are clinical pathways that have been defined, as well as supporting staff that is necessary in a way similar to what is done by the bariatric centers of excellence. There will be continuous assessment ways, specifically, the most important part of which is the the need to prospectively collect data and submit to an AHS-supported database. And then the accreditation body will be the American Hernia Society, led by an accreditation committee. So where are we right now? Like I said, a lot of work has been done. The accreditation committee of the AHS will need to be established. There have been advanced discussion carried on with Care Syntax for the prospective database, and the pilot project will be next for 3 institutions before this being pushed to the public. In summary, we are much further away than we were 2 years ago. We engaged with the appropriate regulatory bodies and other stakeholders, and we have made a great deal of progress, in my opinion. So I think this is an opportunity to move forward from the self-proclamation to validated excellence. Our field depends on commitment to a real measurable quality in order to achieve the designation it needs. And going back to my initial quote, fake it till we make it, I think this is the time to stop faking it. Thank you.
Thanks, Lucian. Next, I'd like to introduce Ben Polos from The Ohio State University, who's going to talk to us about collaborative research ventures to improve hernia care.
Thank you and good afternoon. Thank the moderators and the AHS for the opportunity to present. These are my disclosures. So in terms of research, there's a couple of ways I think that one can go. I think working by yourself as a single researcher is something that's very comfortable for all of us doing. You can only kind of get so far. In terms of collaboration and what you can do together, hopefully I can illustrate in the next few minutes that is really kind of the way that we want to answer some high impact questions, really with team science. If you look at how we've traditionally viewed the 3 things that most of us do, especially in not only in academic centers, but also in non-academic centers, there's also some research and education going on. It's this kind of tripartite mission of research, teaching, and patient care. This is a myth. And I'll tell you why it's a myth. My boss, Tim Pollock, describes it better as a big wheel, that this is what it is. And that is patient care drives everything. And if you think about that, all of us, we want to operate. We like taking care of patients. And if you think a little bit further, this is what drives our ability to do research. And this is what drives our ability to educate, have experience with fellows, medical students, residents. And from a research standpoint, the vision of having every patient in a registry or a clinical trial, I think, is something we should strive for. So how can you do this? I think it takes 2 things. It's finding people, collaborators that are often at your institution. But if you're not an institution that has a wealth of these type of collaborators, there are other ways to do that. Professional organizations such as the AHS and other organizations have really fostered this to some degree. And then you got to find funding. There's only so much you can do without money infusing into this whole mission. And we'll talk a little bit about that. So why would you want to do this? Doing operations and working in our field of surgery is busy enough. Well, this is how we advance our field. As many speakers have explained to us, we can kind of talk about what we do all day and all night, but if you can't really advance the science, that's really kind of limiting what we do. So I think this is the springboard for us to answer some really high impact questions that really we should be focusing on. That's, can hernia repair improve pelvic floor function, pulmonary function? Can abdominal wall reconstruction improve lower back pain? We've all seen a little bit of modulation of that in our patients. What happens at the mesh tissue interface long-term for different types of meshes? Does long-term mesh use cause cancer? Interesting question. Does long-term mesh use cause adverse immune reactions? Also something that, especially in our lay public, is becoming more of a question that is warranting an answer. So some things that we've done at Ohio State is really kind of finding people within our groups that can help us really kind of accomplish this. For those of you who are football fans, last Saturday, the biggest opening game of, I think, the season, and maybe in the past several years, Ohio State, Texas. We beat Texas. It was a lot of fun. One byproduct of having such a strong athletic program in our institution is we have probably the best clinical group of physical therapists in the world, and they also have a really, really strong academic focus. This is Laura Ward. She taught me more about the relationships between the anterior abdominal wall, the pelvic floor, the diaphragm, the lower back than I even knew existed. And so having that perspective available to you was really, really important and really helped us leverage the ability to answer some research questions. So she introduced me to two researchers also in the PT field, Steph DeStacy and Ajit Chowdhury. And we were able to kind of think about this and put together a clinical trial that ultimately got funded by the NIH. And so we just finished accrual of 150 patients in this trial, and hopefully we'll be publishing the results over the next several months here. So putting together this team really was key. And one thing that I think was the most striking is you're no longer the expert when you have a team like this. And that's a little bit of a threat to yourself, but I think it shows a little bit of the humility necessary to get kind of this type of investigation done. And then in terms of professional organizations, the QC, the AHS, ACS, and SAGES all offer opportunities to leverage the expertise from other institutions, other people that if you don't have this capability to have that team, like I showed at Ohio State, you certainly have met people who then can introduce you to a wider group of individuals that can help you kind of get this stuff done. I put this paper out there. This is one of the first publications comparing robotic assisted approach for open using using some of the QC data. And I put this out there. This was published in 2017. The reason why I put this there is two of the co-authors here, Dr. Herrera and also Dr. Balliser, were in private practice at the time. So this whole ability enabled them to access high quality data, access biostatisticians, world-class biostatisticians, to get a publication in a high impact factor journal. And I think that's pretty neat. So common sources of research funding, the NIH, of course, we talked about other federal sources, foundations, local sources, and industry. What I want to focus a little bit on are the ones that we don't commonly talk about and that are foundations and other local sources, which include state funding and institutional funding. So some of the considerations of putting in the time and effort to pursue these things is obviously the time and infrastructure available to you. You're a busy surgeon. You're going to need help putting these grants together, having someone manage all that. If you don't have that, it becomes very, very difficult. What costs are covered by the grants you're asking for, indirect costs, direct costs, and then the prestige involved with the different sources of the funding also is a consideration. So what does foundation funding look like? Something like this. So we had this idea in terms of implanted plastics and trying to get a little bit more idea of what's happening long-term. When we place a mesh inside a patient, what happens 10, 15, 20 years? Amazingly enough, we actually don't know that. And I think that's a problem. That's something we need to answer. Well, it turns out the Herbert Hoover Foundation, the vacuum cleaner company, they're very much interested in these kind of questions. We, through a couple of connections, we found out about this. So they funded this prospective observational study where we are basically going to harvest the mesh tissue interface over time and look at multi-omic gene expression of what's happening at that interface there. And this is the group we put together, again, also leveraging not only expertise at our home institution, but we're working with Rolf Halden, who's at Arizona State University, and he's one of the world's experts in microplastics. So the foundation put us in touch with Dr. Halden, and so this is ongoing. And here's just a little schematic of what we do. These are patients that we're operating on who've had recurrent hernias, had mesh implanted previously, or they're there for another operation, most commonly, say, for a cancer resection. They've already had a ventral hernia repair, and so we're there to not only do the cancer operation, but harvest some of that mesh tissue interface. And we're linking the clinical data in the QC with the tissue data and creating a QC biorepository with this seed funding. So that's kind of a fun thing for a foundation, what you can do with that. So what does state funding look like? So we started this program called Toward Opioid-Free Ambulatory Surgery, taking a cue from our Michigan colleagues who really were pioneers in the ability to reduce opioids. And our central goal was really to develop and implement an opioid sparing regimen, just in general surgical procedures, not necessarily hernia, but that's a lot of where this was applied. You see the regimen there, which is the one we started with. This is funded through the state of Ohio. Actually, they gave us just over $500,000 to do this. And, you know, I will say it took a lot of work, but it was something that could be done if you had a little bit of persistence and a team that had some experience in doing this. So far, we've enrolled over 200 patients, and you can see kind of the breakdown there. Interestingly enough, 58% didn't even fill the opioid prescription. And of those who did, only 4 doses were used. One of the cool byproducts of this got some attention in the city of Columbus. We were able, this is crazy, we were able to actually work with our competing hospitals in the city of Columbus under the leadership of the Central Ohio Hospital Council and implement this all across Epic in terms of order sets that can be used. And we track our data collectively as folks working together try and reduce opioids in a state that's been heavily affected by the opioid problem in the country. So in summary, I think there's 2 things. You need to find people, you need to find funding. And I think this idea of thinking of this whole enterprise is more of a big wheel type of thing where patient care and the operations that we do really drive education and certainly research is a nice way to think about this. And overall, what can this do? It can certainly advance our field and answer the questions that we really, really need answered for our patients. Thank you.
Thank you so much, Dr. Polis. We're going to now invite Dr. Lars Jorgensen to come up and talk about how to create an efficient hernia registry.
Thank you very much. It's a great honor to be here in Nashville. Thanks to Vedra Augenstein and Flavio Malsa for the kind invitation to be here. So, how to create the best efficient hernia registry? I come from a beautiful hospital in Copenhagen. It's 112 years old. The nurses there are standing on the same spot where I have my office, just at the door to the right. I have some disclosures. I'm heavily biased by being the former chair of the Danish Hernia Database. Please bear over with me because of that. Here is the timeline. There are several hernia registries already, and America definitely contributes with a large number of patients being registered. The Swedish and the Danish Hernia Database were some of the first ones. We have a groin hernia registry that was launched first, as in Sweden, and later on in 2007, we launched the Danish Ventral Hernia Database. Great Britain has launched a registry earlier this year, copying many of the same variables as we register in the Danish Hernia Database. However, there are definitely several Achilles heels when you want to create a surgical registry. And the first one is the selection of patients that are recorded in the registry. In many cases, the registries perhaps represent specialized centers rather than non-specialized centers. So they're not really capturing what's going on out there in the country from a nationwide aspect. We have a tough government in Denmark, as was just mentioned by Dr. Kott before. Our registry is the only one where registration is mandatory for all health professionals. It's not only the Danish Hernia Database, it's whenever there is a nationwide health registry that has been approved in Denmark, registration is mandatory. This means also that we don't need to ask for informed consent of the individual patient to be registered in the registry. And it's also said here, only database that has compulsory registration of patients. So actually this reduces selection bias in the Danish Hernia Database. Another important aspect to look at is the burden of a busy surgeon in the clinic. So this is why we decided on creating a very simple online questionnaire to be filled out at end of surgery for the surgeon. And I would say that the time requirement once you have logged on the hernia registry is less than 2 minutes for the surgeon to register the perioperative variables. So keep it simple and make it quick for the surgeon. All the registries that are out there probably register most of these intraoperative and perioperative variables. The whole challenge is, how do we catch long-term complications? How do we catch quality of life? And of course, recurrences. So patient follow-up is definitely another Achilles heel. Most of the hernia registries have an extensive workload, I would say. They have very detailed perioperative data registration. They do register in terms of questionnaires, prompts, up to most of the registers, maximum of 1 year, but there are very limited long-term data. It's expensive, and completeness in terms of evaluating the number of procedures taking place on a nationwide basis is pretty low. So this is very much in contrast to lazy Danish surgeons. We want to keep it simple and very pragmatic. And I will go into details on how we follow the patients. It requires, as I just mentioned before, very little time to register the patients. But the problem is, if you want to do clinical individual follow-up on patients, it's like digging snow, because parallel to the very busy surgical practice, you accumulate more and more snow to be removed, and it's almost impossible to keep on this follow-up activity in a continuous fashion. So this is the way we do it. The surgeon enters data post-operatively into the Danish hernia database. Parallel with this, the hospital, in order to obtain the reimbursement, must report to the National Danish Patient Register. And we use the same kind of code, the social security number and the operative date. So we can check for missing registrations in the Danish hernia database. That's almost 100% in the Danish National Patient Register. And we obtain, by this feedback mechanism, about 90% follow-up rate in the Danish hernia database. Here we report the perioperative data, and that can be combined with data from the Danish National Patient Register with readmission, reoperations, new surgeries, and eventually death. And that follow-up principle continue forever until patient eventually pass away. This was the possibility we had to demonstrate on a long-term follow-up. As you see here, the inferior efficacy of the Physiomesh following lab IPOM in incisional hernia repair. And I think this slide really demonstrates the importance of long-term follow-up, because the curves continue to spread. However, and I have to admit, we only capture the tip of the iceberg. Readmissions, including operations in general anesthesia. We don't capture small bedside wound or hematoma evacuations. We don't capture PROMs, minor events, or less symptomatic hernias that do not lead to reoperations. And we do know that there is a factor, approximately 4 times as many recurrences out there as we operate on. There is an additional opportunity, that is that using the social security number of the patient and the reoperation date, we are able to contact all hospitals in Denmark, both private and public institutions, to obtain reoperation notes, so we can look into details on the reason why the patient was reoperated on. These are studies using this kind of important information, distinguishing between reoperation for hernia recurrence and reoperation for a complication eventually associated with the index repair. Funding, just very few words. I would say that the Scandinavian registries are the only one that are publicly funded. The budget for the Danish hernia database is ridiculously low, only $250,000 a year. The take-home messages here is that the system that we have followed here in Denmark is that these results probably are less prone to selection bias. It's important that the registration of patients is very simple for the surgeon, that it's an integrated part combined with a reimbursement for the procedure to the hospital. It's important that you can merge your data with a national health registry to allow for long-term follow-up. Very important, provide feedback with your results to the surgeons in order to inspire them to continue data registration. The registry must be able to demonstrate quality improvement, as has been the case for the Danish Hernia Registry. It's a fantastic tool for capturing rare events and also for creating important research. Thank you very much, and I apologize for going over time.
Thank you, Dr. Ferguson. Next up, we have Lane Belden, who's going to be discussing beyond the RVUs, alternate strategies for reimbursement hernia surgery.
Hi, everyone. I want to thank the AHS for having me today. So today I'm going to be talking to you about how you can maximize your RVU potential in hernia surgery. It's a controversial subject, but one worth addressing, so get out your popcorn. The AHS has been working with expert hernia surgeons across the country to make formal coding recommendations, but it's still in progress. And my goal today is to help you capture the complexity of the work that we do through RVUs. In January 2023, new codes were introduced for the anterior abdominal wall hernia repairs. Everything I talked to you about today will exclude hiatal, diaphragmatic, lumbar, groin, and peristomal hernias. These new codes no longer differentiate between approach of the hernia, albeit whether it be open, robotic, or laparoscopic. In addition, 0-day globals have replaced the prior 90-day globals that we're accustomed to. These codes focus instead on differentiating between size, recurrence, and reducibility of the hernias. And this table shows the 2023 codes that you are likely very familiar with and their corresponding work RVU values. However, there are several limitations with these codes, along with the latest 2017 ACS bulletin, which provided guidance to surgeon hernia coding. First, width is equivalent to length in the newer codes, but in reality, approaches to wider hernias, let's say a 6 centimeter wide hernia, is often doesn't equate to a 1 centimeter wide hernia that is 6 centimeters long. Second, time and effort and risk are equivalent. I'm not rewarded. The codes treat simple primary and IPOM repairs as equivalent to advanced procedures like TAP or retrorectus, which clearly require more time, technical skill, and risk. And lastly, the 15734 code was excluded in the bulletin from being utilized with MIS techniques and claims that it cannot be utilized in a retrorectus or restopper repair. So let's talk more about this code. It's defined as a muscle, myocutaneous, or fasciocutaneous flap in the AMA handbook. The AMA handbook does not specify approach as the bulletin does, which says that it can only be used in an open fashion. In my opinion, the utilization of MIS techniques should not preclude the use of abdominal wall reconstruction codes. It should be congruent with the newer codes, which don't specify approach at all. Furthermore, the bulletin reasons that the 15734 cannot be coded for a retrorectus repair because it's not a myofascial release. However, there are multiple studies that demonstrate medial advancement when you incise the posterior sheath above the arcuate line. It allows the linea alba to flatten, the rectus muscle to lose its fusiform shape. And when you dissect the rectus off the posterior sheath, you decouple the medial abdominal wall and gain about 2 to 5 centimeters of advancement. In truth, a lot has changed since 2017. And although the newer codes were meant to bridge the gap and adjust for the increase in outpatient hernia surgeries, there's still a ton of room for improvement. If you look at comparative work RVUs between the old and new codes, Dr. Roth earlier this year stated that the average surgeon doing small to medium-sized hernias sees a significant decrease in the RVUs generated from these surgeries. No longer are we in the days of doing intraperitoneal bridge meshing or open onlay mesh. We're doing superior reconstructive procedures which place mesh in the extraperitoneal position, which requires increased knowledge of the abdominal wall and more technically challenging and take longer operative time. AHS recognizes this. For the last 18 months, a committee of hernia surgeons has been working to make abdominal wall reconstruction coding representation more accurate. The bulletin is coming soon. So these are the proposed alternatives to coding in their current state. For primary and intraperitoneal mesh placement, which includes IPOM Plus, there has been no change. You just use the 2023 codes as listed. For preperitoneal hernia repair, specifically when you incise the peritoneum and advance the peritoneum over the mesh, we recommend adding adjacent tissue transfer codes according to mesh size. The 14301 code applies to any size area of the tissue being transferred or rearranged between 30 to 60 square centimeters, and the 14302 is for each additional 30 square centimeters with a maximum of 8. So for example, if you're repairing a 4-centimeter hernia that's incarcerated via robotic tap and placing a 15 by 15 centimeter mesh, you would code 49594 for a first-time hernia repair that's incarcerated and based on size. You would then multiply the mesh size, so 15 by 15, which is 225 to get the total surface area, code 14301 for the first 60, and then each subsequent 30 would give you the units of 14302 that you would code. That would give you a whopping 44 RVUs. And before you scoff at how many RVUs that is, you can see here in this video that mobilizing the peritoneum can be very challenging. On average, it's 113 micromillimeters thick, which is close to the diameter of a size of hair. Mobilizing this without significant defects is an advanced technique and should be rewarded as so. For erector rectus repair, we've had thorough discussions and are currently proposing that intention should play a role in your coding decisions. If you're repairing a smaller to moderate size hernia, so let's say a 4 to 6 centimeter hernia, and the goal is to simply place mesh in the extraperitoneal space, maybe there was a previous underlay or the quality of the peritoneum was poor, then you should not code the 15734, but instead utilize the adjacent tissue transfer codes that I just discussed. However, if you are dissecting the retrorectus space for myofascial advancement of the rectus muscle, then you can code 15734 for each side. And one of these codes will allow you 23 RVUs per side. For component separation, we have similar thoughts. We want you to base your billing on your intention. So this includes all approaches and both anterior and posterior releases. If you're performing a component separation only for extraperitoneal space, so maybe an off midline hernia where the semilunar line is preventing overlap of the mesh, then we would recommend you bill 15734 for the posterior sheath release, and then the tissue adjacent codes, the 14301 and 14302 for the implanted mesh size. If, however, you are doing a larger hernia, an 8 to 10 centimeter wide, for example, then you would require medialization of both the posterior sheath and either the external oblique or the TA. Then you can bill 15734 for each side and each release, which would mean that you could code 4 times in that one surgery. That would give you over 100 RVUs, depending on the size and the recurrence. My final tips and tricks are that if you have additional codes that you are placing, you default to the longest global day period. So this would no longer have 0-day globals. You now go to your 90-day global. In addition, if your institution allows you to place a S2900 code, you cannot do this for the abdominal wall codes. In conclusion, we want to be incentivizing surgeons to be performing procedures on patients based on patient factors and their comfortability with the procedures, not incentivizing or decentivizing based on RVU value. We all need to document, provide steps on what you're doing and why you're doing. And all these new advanced reconstructions are reducing the risk of acute and chronic complications associated with hernia care, reducing costs and reintervention, and improving the quality of life of our patients. We want to capture the complexity of what we're doing and cement the longevity of abdominal wall reconstruction specialization. Thank you. And I put a little table for everyone if y'all want to screenshot it.
It is my distinct pleasure to introduce the last speaker of the day, Dr. Shireen Tofai, who will talk to us about establishing a private practice, pearls and pitfalls.
I just want to thank the committee for asking me to give this talk. I really enjoy and I'm very passionate about this topic. And so thank you for including it in the meeting. We're going to discuss pearls and pitfalls in establishing a private practice. I have no financial disclosures. For those of you who may not know my journey, I started as your classic triple threat. I was in a tenure track position at a university-based medical school. I had over $2 million in grant funding. I won the teaching award every year. I had a adjunct position at our school of engineering. Absolutely had the most amazing job in the world. But it came with a very low glass ceiling, and I did not want my academic potential to be affected by others. And so I was offered a really great job at a different type of institution, private hospital, community-based. It was a very academic-ish job, but it's still a private hospital. And it really focused me on RVUs and generating, being very productive. I was the busiest general surgeon in the hospital, but it was never good enough. And I was there to do research and be teaching and building programs. And at the end of the day, even though that's why they hired me, productivity was really all they were interested in. And the good news is I learned a lot about private practice in this type of situation. And then I learned I can do more, better, and with more independence if I just did everything I'm doing at this community hospital on my own. So I'm now over 12 years in solo private practice and I'm loving it. And I will share with you the pearls and pitfalls of what I've experienced. So let's start with some facts. This journey I explained to you is basically the opposite of what most people do. Most people start in some type of independent scenario. Could be a private practice, whether in group, or independent contractor, or maybe you're a resident or in training or fellow, and then you move to an employed surgeon position. That's typically what we're seeing now. In fact, if you look at the difference between 1980s versus now, in the 80s, over 3/4 of surgeons owned their own practice. And now less than a half own their own practice. So let's look at the surgical subspecialties. So general surgery doesn't do very well in the private practice category. Ophthalmology, orthopedics, the majority of them are actually in private practice. Most surgical subspecialties have a very strong private practice component. If you look at the non-surgical specialties, about 40% are in private practice. You may still be employed within the private practice, but it's still in a private setting. And general surgeons are below that. 37% of general surgeons are in a private practice situation. So already as hernia surgeons, we're a little bit in a situation where most of our peers are not in private practice. And those that are tend to leave. So why do physicians leave private practice? The top 3 reasons are low reimbursement rates per RVU, which we heard about earlier. They're getting tired of dealing with the payer administrative issues, regulatory burdens, and you just don't have access to as many resources when you're on your own. So many of them moved on to larger institutions. And just to give you a little idea of what we're talking about, this is the Medicare annual RVU rate that Congress passes every year. It actually went in the high 40 plus dollars per RVU. Now we're like in the 31, 32 range. But if you correct for inflammation, for inflation, this is what we're looking at. This is a dramatic drop in reimbursement for the work that we do, which makes it very difficult to be on your own. So if you are contemplating private practice, regardless, what are your goals with it? what are your goals with establishing private practice? I will share with you mine. And that was the freedom to fill in the blank. So has anyone watched Handmaid's Tale? The freakiest series ever. But Aunt Lydia of the Gilead made this comment, and I wrote this down because it exactly represents how I feel, but the opposite. So she was telling the girls of Gilead, the handmaids, there is more than one kind of freedom. There is freedom to, and there's freedom from. In the days of anarchy, which is like before Gilead, it was freedom to do whatever you want to do. And now, with this beautiful society that they built, you are being given freedom from a lot of things. And that's kind of how I feel, except I like the freedom to do things. So I wanted the freedom to take my career whichever direction I wanted it to. I didn't want my chair or my CEO of the hospital or my division chief to be the one, or some administrator to be the one that directs my academic career. I also wanted the freedom to expand my interests as I chose. That's patent number 6. I now have 10 patents under my belt, and I have the freedom to do whatever I want with my time. If that includes spending it on getting patents, so be it. And lastly, you can make deep, rapid change when you're small in private practice and your own boss. And I really like that I can make improvements. I can move in a certain direction that I want without bureaucracy, without having to get permission, etc. But you do need a reality check. So for example, let's make sure you understand what private practice is not. It is not an easy way to make money. There's tons of overhead costs. Your institution is paying about 40% in overhead costs for you, whether it's malpractice insurance, your 401k, etc. But that means when you're in private practice, there's about a good high percentage, 25 to 60% of overhead that you have to pay before you take in money. Financial security is not guaranteed. There's no ceiling, which is amazing, but there's also no floor. So you don't have a base salary. You don't have all these things that you can kind of rely on when things go rough. It is not a safe decision, but high risk is also high reward. And it's very easy. It is not easy to develop it anywhere you want. You have to be strategic about your opportunities. And when you are in private practice, all those roles and people, admin, everyone, your manager, your NP, your office manager, those are all roles that you must also now take on as individual. You are the biller, you are your CFO, you are the one that does your marketing. You may not personally do it, but you have to oversee all of these. Whereas if you choose an employed position, you're choosing employed practice because you're choosing freedom from these roles. So here are the pitfalls. My dad used to say, how do you learn respect? It's from the disrespectful. And so I'll teach you the pitfalls and that will be your pearls. So number 1, poor customer service. You have to say yes to everything. Can you see this patient today? Yes. ER is calling for a stupid consult. Yes. Patient doesn't want to see you. Can you do a house call? Yes. Like you have to say yes and be available. Bad front desk staff, that will kill you. Most of the reviews out there that are bad about doctors is about their front office staff. I'll give you a story. My office staff is amazing. This patient was late, and she was telling me that the entire time that she was late coming to the office, she was running through her mind, and now she's going to show up flustered. There's going to be some chick in the front that's going to be pissed off, and she's going to have to explain why she was late, and she's going to get attitude, and the whole office visit will be horrible. That's not what happened. She came in late. My front desk office manager, so kind to her, offered her water. Please have a seat. So sorry you got stuck in traffic or whatever it was. And that completely changed her attitude about the office visit. And that's priceless. But you must have employees that feel that they're part of your team and share the same goals. You got to pay them well. My office, they get bonuses, they get free phones, they want lunch, they can order lunch. they want to go on vacation, they can go on vacation with me. So you keep them happy, and that's priceless. You must have great interpersonal skills. When I was at the county, we never knew the names of our anesthesiologists. It was always anesthesia. Anesthesia, bed up, please. Anesthesia, Trendelenburg, please. I know every single anesthesiologist name. All the referring docs have my personal cell phone number. Even some of my patients have my personal cell phone number. That's just a different relation. There's no wall, and you have to have good interpersonal skills. You must be able to balance multiple roles. Like I said, the freedom from versus freedom to. And then lastly, if you're not able to balance all that with a good life, you are not going to enjoy private practice. Many of you know my friend, Mercedes Bagay. She's a member. She's a surgeon, very busy surgeon, takes lots of call. She really likes her lifestyle. I try to hang out with her because that's us at the Dodgers game, the World Series where we won. Sorry, Brian Jacob. That's us at an NBA game, at a Chargers game. I mean, she really enjoys her life and works at the same time. So you have to be able to balance it. So I'll leave you with this last slide, which is the strategies to be successful in private practice are be focused. Don't be the jack of all trades. Be goal-oriented. Don't get distracted by shiny objects. Have regular business meetings. It's a business. I have a meeting every single week with my coach. I have a business coach. And I meet with my office staff as well. And remember that patients always come first. If it's a paying patient, a Medicaid patient, Medicare patient, if it's a non-paying patient versus a cash patient, they all get the same amount of your time and the same amount of your care. You round just as frequently on one as the other. You treat one just as well as the other. You never let finances get in between you and patient care. And lastly, if you're not having fun, it's not worth doing. So thank you very much.
Many thanks to all the speakers. I apologize, the hour is running late, and I think we're going to have to truncate now. So if you do have questions, maybe you can catch the speakers in the back of the room. Thank you.